The first results of the beautiful study were among the highlights of ESC 2008 in Munich. The trial included 11,000 coronary patients with left ventricular dysfunction who received, on top of optimal preventive therapy, either Ivabradine or a placebo. Well, during ESC 2009, and concomitantly with publication in the European Heart Journal, Roberto Ferrari reported new findings in the subgroup of 1,507 patients who had symptomatic angina.
The effects of Ivabradine and the benefits of Ivabradine in that subset were highly statistically significant, indicating that this is probably the group that derives the greatest benefit of Ivabradine compared to placebo on top of usual care.
This new analysis showed a 42% reduction of fatal and non-fatal myocardial infarction in patients with angina and a 73% reduction of this endpoint among those who had heart rates greater than or equal to 70 beats per minute at baseline.
This benefit was observed despite the fact that patients received optimal medical therapy, including beta blockers. It seems that this is potentially very important for clinicians to know that if you have a patient who has limiting angina symptoms, as well as heart rate above 70 beats per minute and coronary artery disease, you probably need to consider adding to your standard of care, including beta blockers, Ivabradine.
Based on this finding, the beautiful investigators, led by Gabriel Steg, announced in Barcelona the Clarify initiative, a large international registry to include stable coronary patients seen in day-to-day clinical practice.
They will be able to characterize the predictors of outcomes over 5 years because we will have enough data to build a robust risk prediction model. We will also incorporate in the risk prediction model that we're trying to build an important and often overlooked predictor of prognosis, which is heart rate.
The background to today's presentation was a very controversial meta-analysis of smaller studies with rosiglitazone suggesting that rosiglitazone increased the risk of myocardial infarction.
The RECORD study was set up to investigate this controversy. Close to 4,500 patients with type 2 diabetes were included to compare cardiovascular risk of patients not controlled by metformin or sulfonylurea who received add-on therapy with either rosiglitazone or metformin together with sulfonylurea. The mean follow-up was 5.5 years and the composite outcome was fatal or non-fatal myocardial infarction. During ESC 2009, John McMurray updated the findings on the subsequent acute coronary events and mortality.
If you look at total coronary events, there was no significant increase. And importantly, we also looked at what happened to people who experienced a first myocardial infarction. Were they more likely to die during the remainder of the study follow-up? And in fact, there was no excess risk of death from any cause or from cardiovascular death in patients treated with rosiglitazone compared to those treated with conventional anti-diabetic therapy. So overall, we did not see what was suggested in that controversial meta-analysis.
Syntax was also one of the breaking news stories of ESC 2008 in Munich. And in Barcelona, Peter Capitine reported results from the study at 2 years, comparing surgery to PCI with drug-eluting stents in 1,800 patients with de novo 3-vessel or left main disease. At 2 years, major adverse cardiac and cerebrovascular event rates were significantly higher for PCI than CABG, mainly driven by higher repeat revascularization in the PCI arm, with a significant increased risk of MI compared to CABG. On the other hand, there was a significantly higher stroke rate in CABG compared to PCI. The composite safety endpoint combining death, stroke and MI remained similar at 2 years. The investigators concluded that CABG is still the standard of care for patients with complex disease. PCI may be an acceptable alternative for patients with less complex disease.